Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine in Pennsylvania for our members and their patients. Thanks for tuning in.
Hello there, and welcome to the latest episode of the POMA Does podcast, sponsored by the Pennsylvania Osteopathic Medical Association. I'm Lisa Witherite-Rigg. I'm currently serving as the POMA president. I'm also the champion of the education pillar, and we are so proud to be able to offer yet another podcast for CME credit for our members, just another member benefit. Today, we're going to talk about obstructive sleep apnea. We will provide an overview of obstructive sleep apnea, and then we'll extend our discussion to talk about some treatment options that you may or may not be aware of. This is our second podcast that's eligible for CME credit. To claim the credit for this podcast, visit the webpage noted in this episode's description or visit the POMA Does podcast page on the POMA website. This podcast episode was developed entirely by POMA. None of the panelists or planners for this episode have any conflicts of interest to disclose. I'm privileged to be joined today by Dr. Angelo Illuzzi and Dr. Valeri Roth. We're going to start with Dr. Illuzzi giving us an overview of obstructive sleep apnea, the importance of treating obstructive sleep apnea, and some of his pearls of wisdom. So I'm going to turn the program over to Dr. Illuzzi. I'm going to ask him to introduce himself, and we'll start our program.
Hello, I'm Angelo Illuzzi, osteopathic physician. I'm a specialist in pulmonary medicine. I've been doing sleep medicine since the mid-1980s. I go back to when it was originally on paper with giant Nihon Kohen amplifiers. I've done critical care for many years. I'm practicing in central Pennsylvania in Du Bois, PA. I've done critical care here for a number of years. I started a sleep lab here, and we've expanded from 2 beds to 6, and we've gone from just in-lab testing all the way to home testing and progressing through that. And we're going to give you a little overview of what everybody's going to see very commonly in their practices, which is obstructive sleep apnea. So what is it? Definition-wise, basically, it is a disease state where it's characterized by repetitive episodes of either apneas or hypopneas during sleep, which may or may not necessarily result in oxygen desaturation. It's caused by upper airway obstruction, usually in the hypopharyngeal region. And if you've ever heard anyone snore or know someone who snores, people are complaining about it, that person may indeed have underlying obstructive sleep apnea. What is the prevalence? Original studies done in the 1970s in the Wisconsin cohort quoted for men incidence between 2 and 4% if the apnea-hypopnea index was over 5 episodes per hour. And for women, I think it was somewhere around 1 or 2%. Today, those estimates are anywhere from 15 to 30% in males and 10 to 15% of females when it's characterized as an apnea-hypopnea index of over 5 episodes per hour. So it's a common problem. If you've heard the term metabolic syndrome, people like to use that now in medicine and family practice. Combination of hypercholesterolemia, hypertension, diabetes. Obstructive sleep apnea is actually felt to be part of the metabolic syndrome. So very common indeed. In the past, I guess 15 years since the Wisconsin cohorts originally were studied, we have to keep one thing in mind, and that is the prevalence and increase in the amount of obesity in the United States. And that has a lot to do with the number of cases of sleep apnea rising very dramatically. So what are some of your risk factors? Age, one of the primary risk factors. The older you are, the more likely you are to have underlying obstructive sleep apnea. We see it very commonly now, people in their 70s and 80s, and we're getting referrals for more and more patients in their 70s and 80s. Gender, it's more common in men than it is in women, but keep in mind in postmenopausal women, the prevalence is the same between men and women. Once a woman goes through a change of life, she's more likely to go on and develop sleep apnea. Obesity, obviously, obstructive sleep apnea risk rises as body weight and body mass index increase. And then there's other issues which you must pay attention to, especially in the course of your physical examination. So any upper airway abnormality, you have to look at the craniofacial features. You're going to see a lot of people who have issues with mandibular insufficiency. That could be in the form of micronathia or retronathia, sometimes a congenital process, where obviously they'll have an overbite, or the layman's term is a weak chin. Alcohol consumption, tobacco abuse, very common. Benzodiazepine use. So if people are taking benzodiazepine hypnotic agents, there's a strong likelihood that that person may develop, if they're prone to it, obstructive sleep apnea. How does that work? It works because both alcohol and benzodiazepines affect the hypoglossal nerve output, and those patients are more likely to get underlying obstructive sleep apnea. Opiate use, obviously it's a common problem in the United States today. We just all went through the opiate crisis, going through another opiate crisis. Patients who use opiates are likely to have underlying obstructive sleep apnea. And actually, the most common cause of central sleep apnea today is no longer congestive heart failure or CNS disease. It's actually chronic opiate use. Androgen use, testosterone use in hypogonadal men. We see this commonly also. Seems to be a popular therapy for a lot of men nowadays. Family history. If you have a first-degree relative who has underlying obstructive sleep apnea, then more likely you are also going to have obstructive sleep apnea. Hypothyroidism, another common endocrine metabolic cause of obstructive sleep apnea. Polycystic ovarian syndrome in women is also associated with obstructive sleep apnea. Acromegaly, because they develop macroglossia and they develop craniofacial abnormalities with the course of that. And trisomy 21, Down syndrome patients also have about a 50% incidence of underlying obstructive sleep apnea, not a commonly known fact, and because they have mid-craniofacial collapse to some degree. So very common among patients with trisomy 21. What are some of the historical and physical features? So we talk about snoring, obviously, excessive daytime sleepiness. Oftentimes it's the spouse who is the history provider. Most people will deny it. They don't want anybody to know that they snore. It used to be the wives. Now we oftentimes have husbands who will bring their wives in because they snore, and they actually watch them stop breathing at night. If you have insomnia, you have to be concerned about whether it's sleep onset, sleep maintenance. Some patients with very severe obstructive sleep apnea will experience sleep maintenance insomnia. That's because they may be having an event every 10 seconds or less, and they cannot maintain their sleep status. Because of the apneic event, they become hypoxic. Hypoxia stimulates a response in the brain, thereby causing an arousal, and that arousal will then cause them to breathe again, fall back asleep, and they will have another event causing another arousal. And those individuals will sometimes come in complaining of actual insomnia as opposed to snoring with dyspnea. A child who comes in as a ADHD in pediatrics, I assume many primary care physicians are doing some pediatrics, you have to be concerned that they have some sort of sleep disturbance. If adults are sleep deprived, they become sleepy and tired. If children are sleep deprived, they tend to get hyperactive. And many children will have underlying obstructive sleep apnea as the basis of their hyperactivity disorder. And some people, you'll see cognitive dysfunction as a presenting symptom. So some in the elderly, possibly neurocognitive dysfunction is one of the things you'll have to be observant for. Maybe some links to dementia as well. Nocturia, it's not always the prostate gland. People with obstructive sleep apnea will oftentimes report having to urinate frequently during the course of the night. Morning headaches, usually occipital in nature, common in obstructive sleep apnea. Interestingly enough, sore throats. A lot of people complain of a chronic sore throat if they have obstructive sleep apnea, and the reason for that is the fact that the posterior pharynx will undergo a significant amount of trauma during an obstructive event. If you ever heard anybody snorting or gasping or snoring, while all that's going on, it's not just a noise, but their soft tissues are taking a beating in the back of their throat, and they'll complain of a sore throat. Very common. Mood disturbance. So depression, not an uncommon finding in people with underlying obstructive sleep apnea, and I'm sure most primary care physicians will see depression on a daily basis in their patients. So it's something to think about. And also you can see people, interestingly enough, have cold hands and cold feet. Can't explain that one, but that's a common complaint. And what I've learned, actually taught to me by an optometrist, floppy eyelid syndrome, common in obstructive sleep apnea because of loss of elastin tissue in the eyelids. Never knew it, found it out. Optometrist referred a patient to me because he thought they had OSA, and they did. So some of the physical features, if everybody knows what the Malapati score is, used by anesthesiologists to determine possible difficulty in intubation in the operating room, score of 1 to 4. I'm sure you can find the pictures anywhere online. Just Google Malapati score. If it's a high score, 3 or 4, likely that person may indeed have underlying obstructive sleep apnea. Neck circumference, very common. I always measure necks. If it's 17 inches or greater in a male, you have about a 50% chance of having underlying obstructive sleep apnea in a woman. If the neck circumference is 16 inches or greater, there's about a 15% chance of having underlying obstructive sleep apnea. Look for mid-facial deformities, especially in patients with trisomy 21. It's where the maxilla is actually somewhat collapsed, and you'll see mandibular protrusion. Those individuals, highly likely, again, 50% in patients with trisomy 21. Micro and retrognathia, you have to look at the profile of the patient, see if the mandible and the maxilla are lining up, or if the mandible is somehow regressed and there's an overbite. Just having straight teeth isn't necessarily a sign that there isn't any mandibular insufficiency. And years ago, orthodontists didn't do as much with widening the mandible and moving it forward in children who had orthodontic care, and it was mostly about aligning teeth. Now it's different. They do put spreaders in, try to expand the mandible if it's insufficient. Nasal obstruction does contribute to some degree. A lot of patients will have turbinate swelling from allergies. I can't tell you how many deviated septums I've looked at in my career. It's extremely common. It's easy enough to tell whether they're obstructed or not, just occlude one nostril at a time and see if they can actually breathe through their nose. You'd be surprised. I'm shocked here in central Pennsylvania at how many people don't have clear nasal passages obstructed for some reason or another. Enlarged tongue, macroglossia, again, acromegaly, common in that disorder. And a lot of people will just have macroglossia, so finding. So that is not uncommon. Something we looked at. Tonsillar and adenoidal enlargement in children, very common, obviously. And the primary cause of obstructive sleep apnea in children would be tonsillar and adenoidal hypertrophy. You may see patients with a swollen uvula, very common. Look at it. They'll be hanging low in the posterior pharynx. Sometimes they'll be swollen. Edematous is a very common feature. And again, as I noted, the eyelid syndrome, very, very common. How do we make the diagnosis? Now, patients don't have to enter the sleep lab for an overnight study anymore. Home studies are very common. You can get them by mail. We don't do that. We use a 4-channel system here. Patient is brought in and is instructed in how to put the device on, wears it 1 or 2 nights, returns it. It's an excellent screening tool. Most insurances will cover it. Most insurances will actually insist on it nowadays because of the cost of overnight in-lab polysomnography. So it's simple. You've got to get a good history, obviously. And some of the useful tools are the stop-bang questionnaire and the Epworth Sleepiness Score. And it really pays, if you're in primary care, I believe, to screen all of your patients for obstructive sleep apnea, because if they're diagnosed with OSA and treated appropriately, you can really save them a lot of problems in the future. We'll discuss some of that here in a minute. Those would be the recommendations for that. What are some of the treatment options for sleep apnea? The gold standard is CPAP, continuous positive airway pressure, basically going back to the origins of sleep medicine and obstructive sleep apnea. Some of the devices used were actually vacuum cleaner motors that were sort of turned around and used for positive airway pressure. So CPAP is pretty much a pneumatic splint in the upper airway. It's kind of like I tell patients, it's like taking a balloon, partially inflating that balloon so it stays open, not overinflating it so that you can stick it with a pin to prevent the airway collapse. So it's a pneumatic splint. Each patient has a different opening pressure where they'll have events, and then suddenly you reach the pressure that works for them and the airway will pop open and stay open. Some of these devices are, technological wonders. They can do all sorts of interesting things with them, but the principle is basically the same. You can try to increase their comfort with flexible exhalation pressures and humidity, and some of these machines are so quiet you would never know that they're even in the room. And the interfaces, masks, etc., have greatly improved over the course of the years. Obviously, we talk about cessation of alcohol use, cessation of tobacco use, or at least not having alcohol after 7 p.m. in the evening if you're going to bed around 10 or 11. And then also the use of benzodiazepine hypnotic agents is probably counterproductive in patients with underlying obstructive sleep apnea. Positional therapy, another option. We'll see this very frequently. People will have events primarily when they're on their back. Obviously, gravity pulls the tongue back and into the hypopharynx and will cause obstruction. Especially see that in patients when they're in stage REM sleep. Very common. Surgery in kids, tonsilloadenoidectomy is the primary treatment of choice, assuming that they have significant enlargement of the adenoids in the tonsils, oftentimes curative in children. Rare occasions we'll have to use CPAP in kids. There are other surgeries in adults that can be done and have been tried, not as successful as we would like to have been. Laser-assisted uvuloplasty, uvulopalatal pharyngoplasty, otherwise known as U3P. There's also tongue reduction has been attempted, turbinate reduction has been attempted. Most of the times may be partially successful, oftentimes not. The one surgery that in people who have craniofacial abnormalities, such as micrognathia, retrognathia, mid-facial deformities, is maxillomandibular osteotomy and advancement, usually done by maxillofacial surgeons, the mandible and the maxilla, surgical Lefort's fracture, surgically dissect the mandible, move everything forward with titanium rods, and thereby bringing all of the pharyngeal contents forward away from the posterior pharynx. I've seen that be successful in patients who have these craniofacial abnormalities. What are some of the comorbidities associated with obstructive sleep apnea? The list keeps growing. From a cardiovascular standpoint, systemic hypertension, resistant hypertension, very common in patients with OSA. Pulmonary hypertension, usually mild to moderate, but if it's there, you need to treat it. A lot of patients get echocardiograms, and I probably see every patient that an echocardiogram is read as having pulmonary hypertension, because I'm a pulmonologist. Link the two. Ischemic heart disease, myocardial infarction, congestive heart failure, diastolic, systolic disease as well can result as sequelae of obstructive sleep apnea. Right atrial enlargement, left atrial enlargement, right ventricular hypertrophy, left ventricular hypertrophy. Atrial fibrillation, very common, obviously, as populations get older. Most primary care physicians will see a significant amount of atrial fib, and atrial fib has been linked to underlying obstructive sleep apnea. Some electrophysiologists today will not perform ablation unless a person's had a sleep study done and their sleep apnea is treated. Now, that said, there is not a lot of data on maintaining sinus rhythm with the use of CPAP in patients who've had ablations, but those studies have never accounted for compliance in those individuals who failed. Bradyarrhythmias, you might see sinus bradycardia, first degree, second degree, and third degree heart block as a potential problem, especially during sleep, and you may even see sinus arrest in some patients. Ventricular arrhythmias, sometimes PVCs over 30 an hour, consequence of OSA. Group PVCs, non-sustained ventricular tachycardia, and sudden death with left ventricular dysfunction has been reported. Years ago, famous football player, played for both the Eagles and the Packers, had underlying obstructive sleep apnea, refused to wear a CPAP, died a young man, 44. That was commonly reported. Strokes, TIAs, again, reported with untreated OSA, poorly managed or poorly controlled diabetes also, and now chronic kidney disease and progression of chronic kidney disease has been linked with obstructive sleep apnea. And there's some thoughts as to whether or not certain cancers may also be linked to obstructive sleep apnea. Some patients will have neurocognitive dysfunction, depression, anxiety, mood disturbances, work and automotive accidents, and basically a generalized reduced quality of life. For some patients who are diagnosed, placed on CPAP, it's a world changer for them. I've seen patients just have dramatic turnarounds in mood, quality of life, wakefulness. It's just a game changer for some people. Again, we discussed the diagnosis, home sleep apnea testing. It's readily available. It's simple. Most patients can do it on their own at home. If not, then in-lab polysomnogram would be indicated. Screen your patients, Epworth Sleepiness Score, and a stop-bang questionnaire, very helpful in helping to screen patients with OSA. And just a word for the sleep labs out there, when you are referring patients either for home sleep testing or for in-lab polysomnogram, do the sleep history. You should be doing it on every patient as part of your routine annual visits to screen for OSA. It's very common, causes a lot of sequelae that are detrimental to your patient's health. You have a valuable tool with which to change people's lives in some cases.
So thank you, Dr. Illuzzi, for that wonderful presentation. I do have a couple questions I'd like to throw out at you.
Certainly.
Number one, when you do assess that a patient does indeed have sleep apnea, you get them set up with CPAP machine. They seem to be doing well. At what point do you reevaluate them to see if the pressure is appropriate, if they're tolerating it well?
So there's no rule on that. I don't routinely put people back in the lab, nor do I, rescreen them with a home study. I always follow my patients. So the usual routine for us is the initial visit. We have to see them within 3 months, usually within 90 days of getting started on a CPAP machine, requirements for Medicare. So we'll see them in 3 months. They automatically leave here with an appointment for 3-month follow-up. By then, I'll have had time to get them studied, get them titrated, and get them on a machine for at least 30 days. At that period, we are often, because the machines can provide this information, a lot of them have modems, or a lot of them will have SD cards in them. They stopped making machines with modems now because it's the computer chip shortage. So we go back to SD cards. They can be downloaded, and we can get a lot of information off of those cards. The machines can tell you what their apnea-hypopnea index is, whether or not they're central apneas, whether or not they're obstructive apneas, whether or not they're obstructive hypopneas. They can give you the apnea-hypopnea index. They can also tell you what the leak is and what the cumulative usage is, as well as the daily usage is, the number of days and number of hours on average that person uses their machine. So you can get a lot of information. This becomes very important in professional drivers who have CDLs. They cannot get their CDL unless they present this downloaded data to their examiner. And then we'll look at that and we'll just ask the patient, how they're feeling. And if they're a go, if they feel, hey, I'm great, doc, I don't, have any snoring, my wife doesn't complain, I always ask that question, is your wife complaining? And if they say, no, I'm awake, I'm alert, I can drive safely, and I feel better, and the data supports that, then I don't retest.
And you actually just led into one of my other questions. There are certain occupations that if people do not have adequately treated sleep apnea, right, they cannot continue this occupation. The commercial drivers are one.
Right.
Pilots. I don't know if pilots are
routinely screened. I know professional drivers, tractor trailer drivers, they are all pre-screened. And then if they have, as I noted before, neck circumference of over 33 centimeters, roughly 17 inches, or if their body mass indices are over 35, I think they automatically have to be screened. And then, if you're a professional driver, you get a diagnosis of obstructive sleep apnea established, you're going to be, every year, going to have to show that you're complying with a CPAP machine before you can get your certification.
So CPAP machines have really changed over the years, to big monsters, to more compact, better tolerated.
Right.
You comment on that?
Yeah, lots of bells and whistles. The original machines were sometimes the size of television sets. I had a patient one time who had a CPAP machine that was like the size of a microwave. He wouldn't give it up, interestingly enough. Now they're obviously much smaller. You can get them on your nightstand. Masks, interfaces, a lot smaller, a lot more comfortable. The units themselves now have built-in humidifiers. They never had built-in humidifiers before. And they have proprietary terms. There are a few manufacturers. What happens is on exhalation, the machine will sometimes lose anywhere from 1 to 3 centimeters of pressure. So you don't get that sense of exhaling against the forced pressure. and then gradually goes up as you inspire to prevent your collapse. Yeah, they can do a lot of things with a CPAP and BiPAP to make people comfortable. And then there's auto CPAP. We'll have a lot of patients who have auto CPAP tolerate that better. We try not to use it as much, but it is effective, and some people it works wonders. So the units are quiet and they are a lot more comfortable. The interfaces have much smaller footprints, and the headgear isn't as bulky or heavy. So I have a very good success rate. I mean, going into this, everybody would always talk about there just being maybe a 40% success rate. Mine is much better.
So there is going to be a portion of the folks with obstructive sleep apnea that are diagnosed and that are treated, but they just don't tolerate that CPAP machine. What other options?
So the new option now is hypoglossal nerve stimulators. You're going to hear a little bit more of that later, and I didn't mention it in my initial conversation. They've been around for a little while, just kind of breaking onto the scene now. For people who just cannot wear it, I've had a lot of patients who have claustrophobia. We work with them and try to get them to wear a mask. I mean, CPAP still remains the gold standard. But if you are fitted to a category of someone who qualifies for one of those units, certainly an option. Dr. Roth
Dr.
will
Roth
be
will be
discussing hypoglossal nerve stimulation. It's basically, make a long story short, it is an implanted generator, planted usually in the chest, so like a pacemaker. You have a respiratrace device that's also implanted in the chest, and then the generator is obviously connected to a wire connected to the hypoglossal nerve. So there is incisions and surgery involved. The wire is tunneled under the skin to the hypoglossal nerve to the generator, and it stimulates the genuglossal nerve to move forward, to move the tongue forward. So in those individuals who have the right type of obstruction, the device can be a game changer for that individual.
Other than that surgery, what other options do we have for folks that don't tolerate or can't tolerate?
Depending on the severity of their problem, I mean, I have done tracheostomy.
And it's
obviously extreme, but I've had patients who've had apnea, hypopnea indexes or indices of over 100. I mean, the highest I ever had was 147. So, I mean, that means that, like, you're just not breathing. I could show you polysomnography studies that would just, looking at them, would make you break out into a sweat. And these people are doing this night after night after night after night, years on end, until somebody sorts it out.
I remember early in the sleep lab here, I had referred a patient, and it was in the middle of the night that the technician, actually a friend of mine, called me at home and said, we've got to do something with this patient right now. So, our technology has really,
Yeah, computerization has really, I mean, I go back to paper. I mean, I trained on paper, and if anybody ever recalls, young doctors won't even know this, what EEG paper used to look like. It was these massive sheets, and you needed a warehouse to store your sleep studies, and you went page by page, 30 seconds at a time, throughout an entire night. You had to do the whole thing.
Hours
and hours to do this. And now it's computerized. Most computers are 80% efficient at scoring the studies.
Doctor, thank you so much. Thank you for sharing your expertise. And next we'll be talking with Dr. Valeri Roth.
Thank you.
Well, we've heard from Dr. Angelo Illuzzi about obstructive sleep apnea and how the mainstay, the gold standard of treatment, is CPAP, but we do know that there are some folks that just can't tolerate CPAP, and there are some other alternatives for those folks. This evening we have Dr. Valeri Roth, ear, nose, and throat specialist, joining us, and she'll tell us a little bit more about that. Val, would you like to introduce yourself? And then we'll get right to talking about other treatments for obstructive sleep apnea.
Excellent. Thank you very much for the invitation, Lisa, and the nice introduction. So I am an ENT doctor from Western Pennsylvania. I'm in the Sharon Hermitage area. I graduated from PCOM in 1992. And did my residency there as well. I spent time in Walter Reed Army Medical Center in Fort Belvoir, Virginia with the Army. And then I transitioned to Western Pennsylvania, where I was born and raised. I've been here the last 22 years, and I have been employed at one point, but 8 years ago, I went independent and I've been in private practice since then. I am the chief of surgery out here at Sharon Regional Hospital, and I also work at the local UPMC division of Farrell Hospital in the Horizon system. So I'm really excited to be here today to talk about a new procedure that can help with sleep apnea. As you both alluded to, the gold standard for treating sleep apnea at this point is the CPAP machine. And I'm sure, as many of us know, that is not an ideal situation for most people, having to deal with having the cords, the masks, the blowing oxygen. As an ENT, I personally have some prejudices against the CPAP mask because of issues that I find which are aggravated through the sinuses. And I've even had some patients with the air that blows into their eustachian tubes and have ear issues that can occur. I had patients with allergic reactions to the mask. It's just a little cumbersome, and travel issues are difficult. Having a bed partner is also another challenge. So I think that we're always looking for other answers to the sleep apnea issue. When I was a resident and a little more leaning towards the idealism, I was just like, well, people just need to lose weight. So losing weight is always a positive in this arena, but it is not the end all to be all. And as I matured with time, realized how difficult losing weight truly can be. So we need to find other solutions for people. I think another non-surgical option before you might consider a surgical option would be an oral appliance. I firmly believe that you should approach that with a sleep dentist, a specialist in the field. You can get them over the counter, but I think without having that professional and expert standing by your side, you're running the risk of not being successful. You might not be successful with it, but if you do have that professional standing beside you and then you are not successful, that's a different story. The thing that I'd like to talk to you about tonight is a new surgical approach. The more technical terminology for it is open implantation of a hypoglossal nerve neurostimulator array, pulse generator, and distal respiratory sensor electrode or electrode array.
Is there an acronym for that?
I am going to call it by its trade name, which is Inspire. One of the beauties of Inspire is that it really works. We have, through the years, tried other surgical approaches, and the success rate has not been all that wonderful. They are showing a 78% success rate using this implantable device. And they're also starting to see that some people who have had the device implanted, it may drop their apnea down to a mild level, and that continues to improve as they continue to use the device over time. So one of the biggest questions people will ask is who actually qualifies to have this procedure performed? The first thing is your AHI, the apnea-hypopnea index. So you need to have a sleep study that is less than 2 years old, and qualifying numbers are between 15 and 65. So that is moderate to severe apnea. This is not for mild apnea. It does need to be at least 15. The next criteria is the BMI. BMIs may not be the most ideal way to assess somebody's weight status, but for right now, that is the parameter that's being used. And the required number is less than 32. That is not a really large person. And I think as time goes on, we may see that advance into larger people. There's different issues there. One is that the FDA approval came for under 32. The other is as you get larger, your adipose tissue, particularly in the neck, is going to be thicker and heavier, making the surgery more difficult to actually perform. They might switch to a neck circumference, which could allow somebody to be very large through the abdomen and yet have a more thin neck, which is surgically amenable to the intervention. So that may happen, but that's down the road. The age is now down to 18 years old. And the last piece to the puzzle that you need to qualify is a step that we call drug-induced sleep endoscopy, DISE. There's your acronym. DISE. The DISE is performed in a twilight sleep at the hospital. The patient is put into a supine position and nasopharyngeal laryngoscopy. A little telescope goes through the nose to look at the structures at the back of the throat. What we're assessing there is the collapse pattern. If a patient collapses anterior to posterior, they're also a perfect candidate for the procedure. If they collapse laterally, then this procedure won't be helpful. So it would be totally inappropriate to proceed. If there's circumferential collapse, then it's going to be a judgment call. The relative contraindications would include a deviated nasal septum. During any sleep apnea issue where we're trying to correct it, if you have a deviated septum and it's significant enough, you're still not going to be able to get good air through your nose to be able to breathe. And that's true whether you're talking about the CPAP machine, the oral appliance, or the Inspire procedure. So that would be something that should be corrected prior to having the implanted device. Another situation might be significantly enlarged tonsils. And again, removing those prior to doing the implant would be the appropriate direction to go. Other contraindications might include neuromuscular conditions that cause difficulty swallowing and difficulties with speech, a post-stroke patient, certain things like that. So I will take you through the process of the procedure itself. It's an outpatient procedure. That means you come in, you go home that same day. The procedure takes between 2 to 4 hours, and a lot of that depends on the setup. We take a lot of time to get things set up to have the best outcomes intraoperatively. I have my patients wash with Hibiclens at the last washing before the procedure. They need to be shaved from their lower lip down to their nipple on the side of the procedure. We generally try to focus on staying on the right side of the chest and neck, leaving the left side for cardiac plantations should somebody need that down the road. Though we can put these in on the left side as well. We use a special drape to prevent infections while we do these procedures because we are implanting a device. We make an incision on the neck under the jawline and find the hypoglossal nerve. We place a cuff around the nerve. In the room is a team, and part of the team is a neuromonitoring team, and we stimulate the nerve when we find it to make sure that we have the branches of the hypoglossal that we want to include, which are the protruding branches, as opposed to any of the branches we don't want, which are the retraction branches. So we get just the branches we want, put the cuff around it. The cuff is attached to a wire that we tunnel under the skin to the chest wall. At the chest wall, we make an incision and make a pocket where we place a transmitter and a sensor. The sensor goes between the muscles of the ribs and senses a change in pressure when we begin to inspire, thus the appropriate name of the device. The transmitter then receives a message that somebody has initiated a breath, sends the message back up the wire to the cuff, stimulates the hypoglossal nerve, and protrudes the tongue, allowing air to flow freely. It is amazing.
Wow. The technology that went into this is phenomenal. So the implantable device, is it similar to a pacemaker or a generator for a pacemaker or defibrillator?
Yes, very similar. These types of stimulations have been used too with epilepsy and even the nerve stimulators for pain. It's all that same type of technology here.
It goes into a pouch underneath the skin.
It's interesting too when the patients come in that you really can't see much of it. I kind of thought maybe it would protrude a little bit, but really you don't really palpate anything. It does sit just above the pec major and it sits under the adipose tissue. The battery lasts approximately 11 years. There is a monitor on the remote control that does give you signal to let you know the life of the battery that's still in the chest wall. So it's not like suddenly it stops, it's coming and can make plans for changing it.
Tell us a little bit about the remote control.
After the device has been implanted, the patient comes back at 1 week to have removal of the stitches, and they need to keep their arm on the side of the device below shoulder level for 1 month. At 1 month, they come back into the office, and that's when we turn on the device. And we do this through the remote control. The first thing we do is test for sensation. Then we continue to test till we get a little bit of protrusion of the tongue. We don't want excessive protrusion because we don't want the tongue to get sore. We don't want the patient to get discouraged. I explain to patients, this is a journey. We're not like implanting this and instantly you're going to have relief of your sleep apnea. It takes time. And when they come in the office, we set parameters for the starting intensity. We set a start time. So if it takes you normally half an hour to fall asleep, we have it programmed to start at about 45 minutes after you fall asleep so that we're pretty certain you're asleep before your tongue starts getting stimulation. We also have a parameter that we set for a pause button if you have to get up and go to the bathroom. All of that is in the remote. The patient controls the turn on, pause, turn off. They also have the ability to increase the intensity or decrease the intensity. Our anticipation is that they increase the intensity by 1 unit every week. That gives them time to adapt to the new intensity. And if there's going to be any tongue fatigue, hopefully that works through. And then they come back to the office in about 6 weeks after that. And we just assess how they're doing. They have just added an app on the phone. So patients are kind of excited. Just had a fellow in and he was like, look how many gold stars I got. So he can follow his own progress on the phone, which is really nice. And I can see how many times did you turn it off during the night? How many hours did you actually use it? And so we can assess how well the process is going and make adjustments where we need to. At that point, the patient is then again sent home and we set up to do a post-implantation sleep study in a lab. There are certain labs that have technicians who are trained to work with these devices. The patient then comes in and while they're asleep, the technician will take them to their best point so that they have the least amount of apnea. Now, sometimes we don't get 100% AHI of 0, but they will tweak it to the point where we can get the lowest AHI possible. Then they let the patient know, and the patient now has a further goal to get to the ideal spot for them.
So it really does take a lot of cooperation between the physician and the patient, dealing not just with the medical problem, but some of the psychological things and understanding of the patient, of the procedure, how it works, and the implications of not getting the sleep apnea well treated.
I think, too, that one of the things is having a really good rapport with your patients so that they understand this is not a quick fix. And I think that's where most failures are happening, is where people expect they're going to go home and feel great instantly. But when they understand that it's a journey, then I think, you have a really good success rate with it. I've also noticed that a lot of my patients, we are getting control of their physical apnea, but we are now identifying that they also have underlying issues. And a lot of them are actually having PTSD and they're having struggles with that. And that has affected their sleep. They just didn't recognize it because they thought it was all apnea based.
So, once we get the apnea under control, that kind of paves the way to helping explore what other concerns this individual may have that's affecting their life in general.
Right.
That goes back to that whole osteopathic approach. And sometimes it's just a matter of whittling away at the layers. So Val, what kind of complications could potentially happen with this procedure?
Realistically, there are very few. Anytime you undergo general anesthesia for a surgical operation, infection, bleeding, and death are your top 3. Would not anticipate seeing those. We take extra precautions with the infections. Anything else there would be really unexpected outcomes. Realistically, from the procedure itself, I would say the weakness to the marginal mandibular nerve is something that's really rare. But if you're going to see something that may be the thing you pick up on, it has a lot to do with the retraction during the procedure. We have started adding actual nerve monitoring to the marginal mandibular to also help us avoid that complication. The incision site, how it heals, having a scar there. Some people will get irritation of their tongue. Most of the time, that's a transient issue. You could have an allergic reaction to the device, which of course you wouldn't realize that until the implantation had occurred. I have read about needing to reposition these. I'm not sure how that comes down the pike, but I guess that could be a possibility.
Yeah, very few. Now, is there issues or have there been issues with insurance coverage? Certainly I'm sure there's a step therapy that these patients would have to have tried and failed.
Most of the time they do expect that someone has tried CPAP and failed, although sometimes even just having a history of claustrophobia where a patient knows that they're not going to be able to succeed with a mask. The insurance process is kind of in its infancy too. It's really up to the individual insurance. We do have a really strong program where we investigate that before the patient gets to the operating room. So far, though, it looks like most of the insurances are stepping up to cover this procedure.
I can imagine, just with the technology behind it, that without insurance coverage, it would be quite costly.
The actual charge on the procedure is $200,000. The device itself costs $24,000. And we all know that insurance charges are inflated so that you can come out somewhere reasonable in the end.
But again, the quality of life for the proper patient.
Right. The patients that I've had that have done this come in, they're like practically skipping on their way in. They're so excited. It is life-changing. That is the bottom line. It is absolutely life-changing. And a lot of spouses are super happy about this too.
Back to that body, mind, spirit thing.
Mhm.
Well, is there anything else you'd like to add about sleep apnea and the treatment of sleep apnea, your experience with your patients after being successfully treated?
I'm just really excited to be able to be involved in this new technology to offer another option to our patients, because I've seen so many people with the frustrations with the CPAP. I have myself gone through my career watching other surgical interventions that really just did not hit the mark. The traditional uvulopalato-pharyngoplasty, I think if we were lucky, that was about a 50-50 chance that was going to help. And I think for a lot of people, it helped snoring, but it did not resolve their actual apnea, which to me is a little more dangerous even, because now you have apnea and you just can't hear it. There's been a variety of tongue procedures, hyoid bone lifting. There's been a lot of things out there, and there's still, I'm sure, a lot to come. So I'm excited to see what's out on the future, too, on the horizon.
Very good. Well, thank you so much. I'd like to thank both you and Dr. Illuzzi for sharing your knowledge and this information on such an important disease state that affects so many people. Now, as a reminder, this episode does qualify for AOA Category 1B CME credit. To claim these credits, please visit the webpage noted in this episode's description or visit the POMA Does podcast page on the POMA website. If you have any feedback regarding this episode or any other episodes of POMA Does, please email them to poma@poma.org, and be sure to subscribe to the POMA Does podcast series on your favorite podcast platform or POMA's YouTube channel. We will see you next time on POMA Does.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube, or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.